So my topic is the mythbuster that we're trying to bust is that all patients with acute aspiration pneumonitis should receive prophylactic antibiotics. Okay, so that's just my outline and what I'm going to go over. So robust diagnostic data or criteria for aspiration pneumonitis versus pneumonia are very lacking. And pulmonary aspiration is one of the most important causes of in-hospital serious illness and deaths among hospitalized patients. And so here is a nice table that I found from an article published in New England Journal of Medicine in 2001 showing the contrasting features between aspiration pneumonitis and aspiration pneumonia. Mainly aspiration pneumonitis, the mechanism is aspiration of sterile gastric contents versus the aspiration of colonized oropharyngeal material in pneumonia. And pathophysiologically, acute lung injury occurs from an acidic or particulate gastric material in acute lung injury in aspiration pneumonitis. In aspiration pneumonia, there's usually an acute pulmonary inflammatory response to bacteria and bacterial products. Bacteriologic findings in aspiration pneumonia pneumonitis are usually sterile with a subsequent possibility of bacterial superinfection. And then aspiration pneumonia, you usually have gram-positive cocci, gram-negative rods, and also anaerobic bacteria. One of the main predisposing factors for patients with aspiration pneumonitis is having a markedly decreased level of consciousness versus in patients with pneumonia, dysphagia, gastric dysmotility. And in pneumonitis, it can really affect any age group, but usually we see it in young patients versus in aspiration pneumonia, usually we see it in elderly patients. And the aspiration event in pneumonitis may be witnessed, but in aspiration pneumonia, usually not witnessed. And typical presentation for someone who comes in with aspiration pneumonitis usually has a history of a depressed level of consciousness and pulmonary infiltrate and respiratory symptoms developing soon after. And then aspiration pneumonia, any institutionalized patient usually or from a long-term care facility presenting with history of dysphagia and having clinical features of pneumonia and infiltrate on imaging. And the clinical features in aspiration pneumonitis usually can range from being asymptomatic to having symptoms ranging from non-productive cough, tachypnea, bronchospasm, respiratory distress about a few hours after aspiration event. And in aspiration pneumonia, you usually see tachypnea, cough, and signs of pneumonia as well. And so epidemiology-wise, historically, the aspiration pneumonitis was described as Mendelssohn syndrome. And in the Mendelssohn series, about 61 young patients who were otherwise healthy, who were receiving general anesthesia during obstetric procedures, had aspirated. And in this study, it showed that they had recovered essentially within 36 to 48 hours with no clear permanent sequela, despite the initial severity of the illness. And this study also revealed the importance of acid in the pathogenesis of the syndrome. And there have been several experimental studies that showed that the severity of the lung injury increases as the volume of the aspirate is increased and as the pH is decreased. And so the general consensus is that if the pH is less than 2.5 and the volume is greater than 0.3 cc's per kg, these are usually required for that to develop. And also it's important to point out that not everything that we aspirate is mainly gastric acid. Sometimes there's particulate food matter from the stomach, and that can also cause pulmonary damage, even if the pH is above 2.5. Aspiration pneumonitis occurs in approximately 10% of patients who are hospitalized after a drug overdose. It can be a complication of general anesthesia. We see this less often now, but it occurs in about approximately 1 in every 3,000 operations, more likely to occur in emergency surgeries versus the lower risk elective procedures, and also can account for 10 to 30% of deaths associated with anesthesia. And also up to 64% of patients who do aspirate during anesthesia, there's usually no clinical or radiographic abnormalities that develop. So the pathophysiology continued. Usually after you aspirate gastric contents, what happens is that chemical burn occurs in the tracheobronchial tree and the parenchyma, and then an intense inflammatory reaction occurs. The mechanism of this lung injury is usually inflammatory mediated with enzymes, tumor necrosis factor, reactive oxygen species, and neutrophils and complement can play a key role in the development of lung injury. And there have been several animal studies that show that inhibiting neutrophil function and complement activation can actually attenuate this lung injury. And then in these circumstances, the inflammatory response in the lungs probably results from both bacterial infection and inflammatory response from the particulate gastric matter. So gastric acid prevents the growth of bacteria, therefore the stomach contents are usually sterile. And so bacterial infection does not usually have an initial role in early aspiration pneumonitis, but there are some caveats to that. Sometimes the gastric content can be colonized by potentially pathogenic organisms, which may occur if the patient is on any acid suppression, H2 blockers, PPIs, or in those receiving enteral tube feeds, or in those who have a small bowel obstruction or gastroparesis. And bacterial infection may also occur at a later stage of lung injury, which we call secondary aspiration pneumonia. And risk factors, as we all know, the risk of aspiration can increase with the degree of unconsciousness. General anesthesia is a really big one. We have the depression of our protective reflexes, gastroesophageal junction, our laryngeal reflexes, upper esophageal sphincter, all of these which usually provide our normal physiologic mechanisms in preventing aspiration. And then you have drug overdose, alcohol intoxication, seizures, recurrent vomiting, etc. And the sequela of aspiration pneumonitis can show a really wide variety of severity. Signs and symptoms can develop rapidly within minutes to hours after having a witnessed or suspected episode of aspiration. And there was actually a study done on rats which showed a biphasic pattern of lung injury after acid aspiration, which showed that the first peak was about 1 or 2 hours after aspiration. And this was presumably a result from the caustic effect of the low pH on the cells lining the alveolar capillary interface. And then the second phase, which would occur about 4 to 6 hours later and peak, was associated with the infiltration of neutrophils and complements in the lung and alveoli. And then clinically, like I said before, it can range from being asymptomatic to developing severe dyspnea, hypoxia, cough, wheezing, low-grade fever, or silent aspiration. And typically we see patients, in mild to moderate cases, they generally have a rapid improvement in usually 48 hours. But in those who develop ARDS, can develop hypotension, intubation, and eventually death. And one out of every 4 patients who've had macroaspiration events that do result in pneumonitis will develop secondary bacterial pneumonia in the following 2 to 7 days. And so here is a chest x-ray of an 80-year-old male who is after his surgery and was noticed to have a witnessed aspiration during anesthesia induction. And as you can see here, there is a right mid to upper zone consolidation, and the patient's still intubated. And then on the next day, you can see that the right middle to upper zone consolidation is resolving. The patient's been extubated now. And then on day 2 post-op, you see essentially it's resolved. There's no pleural effusions, there's no other infiltrates, and the patient's still extubated. So essentially what this is showing is that a patient who's had aspiration pneumonitis secondary to anesthesia induction had a fast resolution in 48 hours after the event, when typically in infective processes you see typically takes much longer to resolve. So current treatment practices and recommendations are mainly supportive, with airway clearance, suctioning, providing oxygen, managing airway, edema, bronchospasms, and then using positive pressure ventilation if needed. And depending on the severity and extent of the initial aspiration event may include intubation and mechanical ventilation and bronchoscopy. And then prior treatments for aspiration pneumonitis used to include adjunctive treatment with steroids, which is no longer recommended. Even though it's been used for decades, there's really limited data on their role, and they have been associated with longer stays in the ICU and did not show any significant difference in the outcomes. And just continued, despite the lack of evidence demonstrating their benefit, there was a survey that was done recently that showed about 78% of critical care physicians routinely prescribed antibiotics for patients at the time of a confirmed macroaspiration event. And another multi-center study showed about 87% of patients with the firm diagnosis of aspiration pneumonitis received early antibiotics. And then because aspiration pneumonitis presents very similarly to aspiration pneumonia, you can have fever, purulent sputum, leukocytosis. Some clinicians do choose to treat prophylactically, and others withhold and closely follow unless there's any compelling evidence that arises later on in the disease course. So current practices regarding prophylactic antibiotic use. Antibiotics are not needed routinely unless the patient is taking acid-suppressing medications or has a small bowel obstruction. In mild to moderate cases, it's recommended to withhold antibiotics even if there is radiographic evidence of an infiltrate, and by monitoring, looking at clinical and radiographic findings and reassessing the patient 48 hours after the event. And then in more serious cases, when the patient is requiring intubation or in shock, antibiotics are recommended to be started empirically, and then the decision to continue this after day 2 or 3 of therapy should be guided based on the clinical course and how the patient's doing. Here is a retrospective cohort study that was done in 2003 and published in the Geriatric Journal of Medicine. They looked at 195 cases of aspiration events in nursing home residents, and they had basically broken it down into aspiration event, which was either definite, witnessed, or unwitnessed, or suspected event. And then they broke it down into aspiration pneumonitis, which they had defined as having signs and symptoms of a lower respiratory tract infection, and having a history of the aspiration event prior, and a lower lobe infiltrate on chest x-ray. And then aspiration pneumonia was defined as similar to aspiration pneumonitis, but having no history of aspiration event. And the results showed that about 73% had received antibiotics in the emergency department, and of those patients, 90% of them were continued on those antibiotics on admission. And essentially the results showed that there was no significant difference in the hospital mortality between these 3 groups. The ones who received antibiotics had less days of treatment, and the ones who had aspiration pneumonitis had a less length of stay and were more likely to not receive antibiotics while in the hospital. And this is another study that was done. It's really the biggest and only study that we have for prophylactic antibiotic use. It was published in 2018 in the Clinical Infectious Disease Journal. Retrospective cohort study that initially screened 1,400 patients and only included 200 in the study, 76 of which had received antibiotic prophylaxis and 126 which received supportive care. They had assessed the outcome of the patients who received antibiotic prophylaxis versus the standard supportive care 2 days after the acute aspiration pneumonitis event. And these patients specifically had to have had a witnessed macroaspiration event and were non-intubated. And the primary outcome that they were looking at was a 30-day in-hospital mortality, and secondary outcome included transfer to critical care, antibacterial therapy received, and whether or not they needed escalation of therapy, and how many days of antibiotics-free days that they had following the acute event, looking from days 3 to 14. So the results showed that about 38% who received prophylaxis, 62% received supportive, and the prophylactic group was no less likely to require critical care, and there was a more frequent escalation of antibiotics, and there were fewer antibiotic-free days in that group. And the unadjusted in-hospital mortality was pretty comparable, and in showing that in the antibacterial prophylaxis group did not have any associated improvements in mortality. And here is a table from this study that was basically looking at the patients who had received prophylactic antibacterial therapy after an aspiration event, and this is the one patient who had been receiving supportive care and then had received escalation in antibiotics. And so what they're trying to highlight here is that the people who had received initial prophylaxis had eventually required antibiotic escalation to more broad spectrum antibiotics, and these are the days that they were escalated, and these are the indications as to why they had been escalated, in comparison to the one that had received supportive care and needed antibiotic therapy. So essentially what they were trying to say is that in those who had needed more antibiotics later, frequently with a broader spectrum of antibiotics, what they're saying is that it supports their hypothesis generally that this can increase the antibiotic selective pressure and result in the need for escalating antimicrobial therapy in the event that there was a secondary aspiration pneumonia that developed. The supportive management of patients with acute aspiration pneumonitis may be preserved with the use of antibiotics in a potentially developing infectious process, and that can potentially allow them for a shorter period of antibiotic use if withheld initially. So this study obviously had several limitations. It had a small study size, it was retrospective and observational, potentially could have had many confounding variables that influence what happened to the patients, one of them being that the ones who had more severe initial episodes tended to receive prophylactic antibiotics. And the study wasn't designed to evaluate the impact of prophylaxis on the subsequent development of pneumonia. And they had only studied non-intubated patients who had witnessed macroaspiration and did not apply to patients who had silent aspiration or in those who the diagnosis of aspiration pneumonitis was a little bit more ambiguous. And so I just looked at a couple of other sources that had discouraged the use of antibiotics prophylactically in those patient groups. In NEJM, Merrick in 2001 had basically said that the use of antibiotics shortly after an aspiration in patients who do have fever, leukocytosis, and pulmonary infiltrate use is discouraged because of the increased risk of resistant organisms that can develop with someone who has an uncomplicated pneumonitis. And then in 1976, Bynum had done a retrospective analysis of about 50 patients with observed aspiration of gastric contents, and he had looked at he broke it up into 3 different clinical courses and patterns. 12% had died shortly after aspiration, 62% had a rapid clinical and radiologic improvement on days 4 to 5, and 26% had rapid improvement but had a subsequent secondary bacterial pneumonia, and 60% of those patients had a fatal outcome. So essentially his results had demonstrated that the steroids that they had been using at the time and prophylactic antibiotics did not demonstrate any effect on the outcome of the patient's mortality. He also did demonstrate that gastric aspiration can denude the airway and destroys the usual defenses that we have that typically clear aspirated bacteria. He examined lung clearance of bacteria in acid aspiration models in rats versus the normal lungs in rats. And it showed that the acid damage had a substantial decrease in clearance of the instilled bacteria, and that using the appropriate antibiotics is significantly less effective in clearing the bacteria from the acid-damaged lung. So this is an algorithmic approach that was published just recently in New England Journal of Medicine by Mandel, where they kind of look at aspiration events as like a clinical spectrum rather than putting them into 2 different categories. And so what they had been suggesting is that they look at community-acquired and hospital-acquired or long-term facility. In patients who present with, possible aspiration event, pneumonitis or pneumonia, in those who have a clear chest radiograph, it's recommended still for mild to moderate cases to withhold antibiotics and observe and reassess in 48 hours. And in those who have severe illness, those who are intubated or in shock, to treat them based on their risks. So looking at the poor dentition, or if they're on acid suppressors, or if they're on enteral tube feeds, or if they have any other risk factors like outlet obstruction. And then the same goes for those who are hospital acquired as well. The management for that, or the recommendations for that, didn't change. And so why is this important? It's undeniable that antibiotics can reduce mortality in patients who have pneumonia, but it's really important that we have good clinical judgment in kind of assessing these patients and reassessing to see if they develop a superimposed bacterial infection. So, looking for new fevers or higher fevers, worsening infiltrates, worsening leukocytosis, and any evidence of growth bacteria on sputum or gram stain. And then also, just to reiterate, risks of using prophylactic antibiotics, they should not be minimal, because it can expose patients to potentially unnecessary antibiotics. There's several side effects to antibiotics, increased C. difficile rates with overuse of antibiotics, and then also with overuse of broad-spectrum antibiotics, you see the emergence of antimicrobial resistant organisms, and then including high treatment costs for these people. And then some take-home points for this talk is that usually in the management of aspiration syndromes, it's important to really try to distinguish aspiration pneumonitis from aspiration pneumonia. It's a little, there are some gray areas, especially since some of them are not witnessed and some of them can be silent, but they do come from two different pathophysiologic backgrounds, and they're two distinct clinical syndromes. So just from the recent recommendations and the studies that are very limited, prophylactic antibiotics are not indicated, at least initially, in the majority of patients who do have an acute aspiration pneumonitis. But you do have to keep in mind those who are at higher risk, who have small bowel obstruction or on acid suppressants, et cetera. And then just based on the current studies that have been done, prophylactic antibiotics in acute aspiration pneumonitis has not been shown to change the overall outcome, duration of hospitalization, death rate, or the subsequent development of a secondary infection. But obviously we still need much more large-scale randomized control studies to validate any of this data. And these are my references.
So before I ask for comments, this is a problem that continues to plague us, I would say, in the ICU. We see a lot of patients with aspiration, or what we think is aspiration. We get there's a lot of pressure not to treat patients, and personally, I'm still unconvinced that we shouldn't treat a lot of the patients, at least the ones that we're seeing in the ICU, because they are very sick. Most of these recommendations talk about, differentiating between mild to moderate and severe, but there's no definition for what that means. And in that algorithm that you just saw that was just published, they said if the chest x-ray is clear, observe them. Well, if the chest x-ray is clear, you're not even going to make a diagnosis of aspiration pneumonitis based on their definition. So that doesn't make any sense either. So I welcome comments at this point. Lynn, Dr. Fitzgibbons?
Yeah, so I actually, as you flew by the algorithm, I was actually pulling it up, and this is astonishing. This is a big difference in kind of what we've been told for a while, right? So how do you interpret that algorithm?
Well, I interpret it as, the way they broke it up is that all aspiration events kind of fall under the same window, and based on the imaging studies, and if it's abnormal and if they're community acquired, they break them up into what kind of antibiotics are better used for those groups of people. And then the clear chest radiographs, mild to moderate, obviously, and then severe, they're still recommending antibiotics. But they had mentioned in the same article that in patients who do have mild to moderate aspiration pneumonitis, that even if they do have an abnormal chest radiograph, to still not give prophylactic antibiotics and just observe for 48 hours to see if there's resolution.
Which isn't exactly what the algorithm here is.
Exactly, yeah, and it was written in the same article, but it's not.
I would say, I went out with what Jeff said, I think this algorithm really tends to tell us that if there's abnormalities in the chest film, that while we can kind of discuss the finer points about which antibiotics to choose, we should probably be using antibiotics, and that's a little different than we've kind of been told. And I think the other thing that's worth pointing out, you didn't say exactly what the patient population was for the CID article, but I understand it was primarily mild to moderate patients, because one of the secondary outcomes was actually transferred to the ICU. And so I think it's worth just pointing out that, again, by definition, even if they had abnormalities in the chest x-ray, that population studied were not the critically ill, poorly oxygenating, unwell patients. That's all I have to say.
Yeah, I agree. And one of the problems with that study was there was no attempt at looking at severity of illness of any of the patients. So even though it was retrospective, it wasn't randomized. So we really don't know. Presumably the ones that got antibiotics were probably felt to be sicker, and that may be why they got antibiotics. So, it goes back to the Dilbert cartoon, bad data, but it goes along with what people say, so we do it anyway, maybe. I don't know. So, is it a myth? All patients with acute aspiration pneumonitis should receive prophylactic antibiotics. Well, the way this is worded, then, all. Clearly, some of them probably shouldn't, but let's vote. How many think that this is a true statement, that it's confirmed, that all patients should receive antibiotics? How many think that it's plausible? Some, yeah, we got some there. And how many think it's busted? All right, well, I guess it's a consensus.